We'll go to our next presentation by Dr. Mirvat Alasnag. She will talk to us about the different technique for bifurcation PCI.
Assalamu alaikum wa rahmatullahi wa barakatuh. I think Dr. Subhi made it very easy for me to kind of seamlessly get into my presentation. Different techniques for the bifurcation stenting. And I really, I'm going to try to zip through this first part for the sake of time, but we do recognize that about 15 to 20% of all PCIs are in fact bifurcations. And they are the most challenging, primarily because they have higher rates of complications, stent thrombosis, and in-stent restenosis, and so on. And one of the most dreaded is obviously side branch, losing your side branch. So optimal management to date, to 2022, remains debatable. We have some data outside that has been published, but you do see a lot of variation in the data. And the bifurcation strategies are numerous. You know, you go from T and TAP to DK crush to now nano crush to Culotte and provisional stepwise and so on. So how do you choose which? But you also not only have to choose, you have to understand the caveats and the limitation of each. So the TAP and the neocarina is an issue, nano crush. Looking at the shoulder, that you've adequately crushed it. Culotte, you want to make sure you have adequate main vessel overlap and you don't want the gap with a T. But when we look at the totality of evidence, we do know that outcomes are worse with a systemic dual stenting technique. And so hence, most of the guidelines, including the EBC document, actually recommend a stepwise provisional as the default strategy with exceptions. So what are the exceptions? Again, Prof. Subhi already just told you the Medina classification is the one that is actually quoted in all the guidelines. The true bifurcations are the ones circled in red, 111, 101, and 011, meaning both the main vessel and the side branch have some involvement, and hence it's a true bifurcation. The anatomy, it's not two vessels. You're not looking at two tubes. It's more than two tubes. It's the main vessel, it is the side branch, but it's also the trigon, and it's also the angle of the bifurcation and the carina. But really, we tend to underestimate the role of the side branch in determining the strategy. It is, in fact, a key player. So when we look at the side branch and looking at, do you want to tackle the side branch first of all or not? So are you going to predilate? There's obviously advantages and disadvantages to that. Very briefly, you may consider it if the side branch access is difficult and if there's significant stenosis, and you want to make sure that you're able to re-access it. Disadvantages are, of course, whenever you dilate, you run the risk of dissection. And so even though you may have opted for an initial provisional strategy, you may wind up simply because of dilatation and a dissection requiring some kind of stenting, second stent. But then now moving on, how do you choose between an upfront or an a priori two-stent strategy versus a stepwise provisional? So first of all, stepwise provisional does not mean it's a failed provisional. And secondly, provisional really means you're going to start with step A, but you already have in mind step B, meaning if you need to stent the side branch, you already know up front what is your likely strategy. You're not really thinking on your feet. And so an a priori or an elective two-stent strategy, again, you'd really look at that side branch. Is it a true bifurcation? Is the lesion in the side branch more, is the vessel significant? Is it more than 2.5 centimeters? Millimeters? Is the angle more than 70 degrees? And is the lesion in the side branch length long enough, meaning more than 10 millimeters? Those are the cases where you would consider an upfront two-stent strategy. And again, it's really less than 20% of your cases that will require an upfront strategy. This is published and it's a little complicated, but effectively this was, I just mentioned it and Prof. Subhi did the definition 2 criteria. So look at 1 major, 2 minor, and then move along. But remember, if you started with a provisional strategy, you really can't go to DK crush with that, right? Your DK crush is an upfront two-stent strategy where you want to secure the side branch. It's suitable when your side branch is difficult to access, and there's a significant mismatch between the side branch and the main vessel size. TAP is ideal when you have a wide bifurcation. It is least ideal when you have a very narrow bifurcation because you can have a geographic miss on the contralateral angle, shoulder. Culotte is, you have to bear in mind that this has the longest overlap and 3 layers of stent, but also it's most ideal when you have the side branch and main vessel similar in size. Again, without belaboring but this is the angle that's going to be very determinant, a narrow angle versus a wide angle. Stepwise provisional. So this was a case from our lab. You see disease of the LAD in the diagonal. We wired both, treated the main vessel with the hope of just getting away with a provisional strategy. You can clearly see in the second angio that the long diagonal branch, there's compromised flow after stenting and optimizing the LAD stent. So now we have to go back. When you do proper proximal optimization, it actually facilitates recrossing into the side branch. And this is what you see in the upper margin. You stent the lesion, making sure that you do have a balloon already parked in the main vessel, and you do kissing inflation. Now it is really a stepwise or sequential kissing inflations with minimal protrusion into the carina. Again, this is the LAO caudal or spider view. Key is to find the angle that's going to open up, or the projection that's going to open up the bifurcation, and particularly the ostium of your side branch. Proximal optimization, particularly in a tap technique, you want to stay clear of the metallic neocarina so you do not deform it. And this is the final result after we did a tap technique in this patient, both cranial and caudal views. So very quickly, before kissing balloon inflation, you look at the short axis and you can clearly see, apologies. So you clearly see the protrusion. What you're doing after a kissing balloon inflation is getting the struts all into their right place. So A, you want to get the right configuration when you're doing sequential inflations. And when you're doing your proximal optimization, you're staying away from the carina. I forgot to mention that when you're doing a kissing inflation, the other thing that you're doing is actually centralizing the carina. So you're allowing it to be centered and to give you a more normal anatomy. Unfortunately, a lot of the evidence for tap technique comes when it was used as a bailout. And hence, of all the two-stent techniques, the outcomes from tap appear to be the worst. But they're not really the worst. You have to recognize this is not an upfront strategy in all this published data. The bulk of it was bailout, 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 but not really an upfront strategy. So this is the technique. These videos are available everywhere. Again, I don't think for interventional cardiologists you need me to go through it, but you have to wire both vessels, and then you go ahead and you do your inflation. I'll fast forward. You deploy your stent. You do your ballooning, and in particular proximal optimization so that you don't go under the struts, and you can rewire. And then, most of us do pull the wire from the trapped wire out. We do kissing inflations, and then we go ahead and we do our stenting. This is, a new technology that's been published, and EBC and the European Society have actually talked about it a lot. It's where you actually do 3D modeling for your individual patients, and we've actually started doing it in our hospital. And it's very interesting because you can actually tailor your approach to a very specific anatomy, and you're not guessing anymore, and you're strategizing before you practice on the patient. Critical is what I mentioned previously, is the proximal optimization in a tap technique. You want to stay clear of the neometallic carina. Again, this was mentioned in the previous talk, and I think it did come up in the discussion. When we size stents in the main vessel, it's primarily sized to the distal reference. So proximally, you're undersized. When you do pot, you want to do an appropriate pot. Two things you achieve. You get appropriate apposition and expansion in the main vessel, but you also cover the shoulder of the side branch, and often you optimize access to the side branch when you do proper proximal optimization. Culotte, again, these are some data, including this trial from 2009, but the most important is the Celtic, again showing no real increase in outcomes. Interestingly, this is contemporary. They used radial access, so it is suitable. Again, I know I'm running out of time, so I'm going to really zip through this, but effectively, after you stent the main vessel and you do your proximal optimization, you do see in the middle you have a very significant amount of overlap, more than any technique. And this is where you get your culotte. You rewire, you have to do proper balloon dilatation sequentially, and then you need to do your proximal optimization once again. Effectively, what ends up happening is this is what you're doing with the culotte technique. You do have what looks like a trouser effectively, and you do have the longest segment, but you do want to open both branches at the end, and it facilitates the access. So this is a new development in the Culotte. It's called the DK Culotte, where you add an extra step. This is one of our patients from the military hospital, where you see disease in both the distal left main and circumflex. You have to do the dilatation and so on. But effectively, after you end up placing the stent, doing proximal optimization, you bring in your next stent, and what you can see here is we're trying to do some sequential inflations. On FAST, in the cranial view, we're deploying the stent in the LAD, but you already see the stent placed facing you in the circumflex. And again, proximal optimization, and when you do proper proximal optimization, once again, it facilitates recrossing into the side branch. And this facilitates crossing of the balloons as well. And then again, you do sequential inflation. That's what you're seeing on the top left. And then middle, you see both balloons inflated, and then you see the final result. Proximal optimization, if you chose, like this left main was normal ostium, you do not need to stent all the way back. DK crush, well, DK crush is the final technique, but actually it's taken a lot of evolution in the last decade and a half, from classic crush to step to mini crush to DK, nano, and so on. Bear in mind that the nano and DK nano actually don't have much published evidence yet, and so we really stand in terms of evidence at DK crush. DK Crush 2 looked at DK Crush versus provisional. DK Crush 3 looked at DK Crush versus Culotte in the left main specifically. And 5 looked at DK Crush versus provisional in the left main. These were series that were done in Asia and actually suggest that if the target lesion failure was much lower in an upfront two-stent strategy, and really very different from some of the other European studies. Again, looking at this, you have to do these steps very meticulously, where you're crushing appropriately. I think the only thing I would say with the DK crush, don't be afraid to take an appropriately sized balloon to crush. If you don't do an adequate crush, you make it much harder for yourself. You can see it here in this kind of a model. Again, I'm going to move it very quickly. When you don't do a proper crush, look at what you're left with. Actually, it's much higher to wire this side branch with a vessel that is not appropriately, a stent that's not appropriately crushed. Okay, so I've been terminated, but in any case, these are the main techniques, and I think the only thing that I would say is intravascular imaging. I didn't get to show you those slides, but intravascular imaging for optimization is critical.
Thank you very much, Dr. Mirvat. As usual, it's an extensive overview of this strategy. And just any question from or comment from Dear Banat, Dr. Ahmed Imam?
Yes, thank you for your nice talk. I only want to ask you a very basic thing regarding the guide catheter and the axis. Do you have any preferences using, for example, 7 French versus 6 French, in which technique? And femoral also instead of radial. Do you have any preferences in different techniques?
So I think you can use radial access safely and comfortably, provided you're coaxial. And now we have the slender sheaths, and the slender sheaths do give you an effective lumen that will permit you to take what you need. I do prefer 7 French, although the majority of stents now you can use in 6 French. The reason I do it is when you use big proximal optimization balloons, it gets very sticky and very uncomfortable. So A, I like to give myself room and use 7 French, and B, if you have a complication, you need to put in a covered stent or what have you. So I generally would go with 7 French. Radial is not prohibitive, provided you are able to be coaxial. But you know what? If you do safe femoral, ultrasound guided, etc., do it.
Great. Dr. Hani Ragi?
Yes, thank you very much, Dr. Alasnag. This was an amazing presentation and very complementary to the one before. My question is about training fellows, because we see all those amazing diagrams and we see experienced operators doing it live, and it looks easy. But then people start doing it and they can't recross, and their balloons don't cross after their wires cross, and they abandon essential steps, and the patients come back with restenosis. And many procedures are not completed in real life because the operators saw it on a diagram, thought they could do it. So my question is, when we're training people, how much simulation should we use? Should we have a toolbox to tell people, for instance, to use new balloons when they are trying to recross double layers of stents? You know, it's not clear. Even the European Bifurcation Club doesn't mention anything about the number of wires, if you should use a new wire, if you should use new balloons, you know, and people work with different, and that is my concern, the training to do all those procedures.
So these are expensive procedures, yes. You go through a lot of wires and balloons and so on, and I think depending on your comfort on reusing balloons, but I wouldn't jeopardize a bifurcation by reusing a balloon that can damage struts. In terms of training, I have my personal bias. We just said that 15 to 20% of PCIs are bifurcations, of which less than 20% are going to need an upfront two-stent strategy. So I don't believe in diluting the experience. I believe if you have a complex bifurcation, refer to somebody with expertise. I believe if you're a fellow in training or even an early career who is not comfortable with troubleshooting and rewiring, and a lot of it is, yes, technical skill, but judgment. So I would say refer. But if you can't refer and you want to learn and you want to train your fellows, etc., then I would say pair up. What I did is I paired up. You have to have somebody with expertise to learn from the technicalities, and every patient is very different. So somebody who can bail out the rewiring, somebody who can think of plan B and C if you're unable to rewire, somebody who can interpret the intracoronary images and tell you, yes, this is what's happening, and so on.
Thank you.
Great, Dr. Kamal. If you allow me, Dr. Kamal, just go ahead.
Just quick, I enjoyed actually, I enjoyed your talk, Dr. Mirvat. Just one question. You said that there is an extra move or extra step in DK Culotte. I didn't get that. Probably you pass it very quickly, number one. Number two, I really think that there is no best technique for bifurcation stenting. I think you do the technique that you are comfortable with and that you master. You do it, learn the right way and do it the right way, and it will work all the time. But don't concentrate on the names and yeah, if you just give me, Dr. Mirvat, the extra step, I didn't get it, I'm sorry.
So the DK Culotte is effectively you add an extra kissing inflation before implanting your second stent. So after implanting your first stent in the main vessel and after doing the appropriate post-dilatation, including proximal optimization, then you recross into your side branch, do a kissing inflation. This actually helps you deliver your second stent. And then after you've done your stent, you do your similar steps. So now you're going to have a second kissing, obviously, after your stent was deployed, your second stent. So this additional kiss has actually done two things. It actually helps expand, it helps scaffold your shoulder, and it helps you deliver your second stent into the side branch.
Okay, great. Last question, Dr. Samih.
Yes. First, thank you, Dr. Mirvat, for elaborate presentation. I learned a lot as well. Don't you think it's about time to leave the very complex double stenting to the rarest of our practice, and to avoid even using it as a fellow approach rather than an expert consultant approach? Why don't we just, as things are evolving now, we have introduced the drug-eluting balloons, and at least my experience, and I've seen it also with others, that now almost rarely, except for the left main bifurcation, that I use a double stent. Now what I'm doing is drug-eluting balloon on the side arm, unless when I cause trouble to the branch and I dissect it, which can happen, and a single stent. The way I made my practice ongoing and seen the successes is that I use actually a scoring balloon to the branch, which has a lower rate of dissection and a lower rate of recoil, including the ostium, and then treat it with a drug-eluting balloon, even when the angle is acute, halfway through, or even obtuse. At the end, I'm getting the same result with less metal and less likelihood of causing trouble at the junction with the carina. What do you think?
So very quickly, yes, I agree with you. Again, provisional is probably the way to go. And if you can use drug-coated balloons, good and well, that sounds like an attractive option. We have very limited evidence for its use, particularly in true bifurcations. That's number one. Number two, again, we're all operators. You cannot guarantee you're not going to get a dissection with a drug-coated balloon or an angiosculpt balloon or a cutting balloon. So you always have to have plan B ready. So stepwise, provisional. But yes, attractive.
Great. I will just deliver a question to Dr. Thank you very much, Dr. Mirvat. Dr. Haytham, maybe also with Dr. Gamra, because you have already a lot of experience. How many times in a cath lab you do a single stent strategy and the team beside you say, we cannot leave this diagonal, or and the patient come later on after years and nothing happened to that side branch, and you get away with it?
So the question is when do I leave a side branch untouched? Well, if there is TIMI3 flow, if there is no dissection, if the patient, even if there's a pinch and it's only focal, we know from hemodynamic data that focal side branch lesions, if you FFR them, 75% of them will be negative. So you leave that alone. And then if the patient has no symptoms, so even though there may be a tight stenosis, if there's no symptoms, I actually shy away from tackling. Always less is more. But if it's really big, if there's decreased flow, the patient has symptoms, you have to go ahead and salvage that. And the same issue is with the circumflex, of course, if you're dealing with the distal left main. So these are my simple ways of dealing with these cases. Now, rarely I've had jail diagonals that came back with STEMIs a year or two down the line. I've seen that rarely. So provisional LED stent, the patient came back 2 years later with a lateral MI, and it was that diagonal, and I had to stent the diagonal 2 years later. So I've seen that rarely, but the majority you will get away by doing nothing. If you have these criteria with no symptoms and good TIMI flow and just a focal lesion.
Excellent. Thank you very much. And